Thank you very much for um, introduction. I am honored to be part of this webinar and sharing the spleen stiffness or spleen elastography thoughts and concerns with you. I'm a hepatologist from Cluj-Napoca, Romania, and I will try to share with you some insights about spleen stiffness. This will be the organization of this talk. First, we'll speak about why performing spleen stiffness, so which are the main indications for that, and in the end, how to do it by sharing some technical aspects. Well, everything starts from liver stiffness. Because it was demonstrated that liver stiffness is very well correlated with portal pressure, but only up to the level of 12 millimeters of mercury. After that part, the correlation is somehow lost. And this is important because after that value, the varices and the risk of bleeding appears. So liver stiffness, it's not a very good tool to predict the variceal bleeding. And this was further demonstrated in large trials with very modest diagnostic performance for liver stiffness. This is why spleen came to attention, because it is correlated, it's very much implicated in the pathophysiology of portal hypertension, and enlargement of the spleen goes with changes in elasticity. And then it was just a little step further to measure the spleen elasticity and try to make some correlations in order to better understand the changes in this condition. And indeed, first reports demonstrated that the spleen stiffness increases as the liver disease progresses. So it's much higher in patients with liver cirrhosis than in those with chronic hepatitis or compared with normal subjects. But when it came to cirrhotic patients, it was not able to differentiate between various grades of varices, but could differentiate patients with varices from those without varices. And further reports demonstrated a very good correlation between HVPG and spleen stiffness with much better than the liver stiffness. And what is important is that spleen stiffness was able to better predict the presence of clinically significant portal hypertension and presence of esophageal varices than liver stiffness alone. The problem was, however, that with the normal FibroScan, which was the first method used to measure the spleen stiffness, which is transient elastography, the problem appeared with the intrinsic characteristic of the machine. It was a ceiling effect. So no matter the grade of varices, the upper value of the machine was reached. So a differentiation between grades of varices was not able to be done. Then an idea came to change the characteristic of the FibroScan probe. So the frequency of the mechanical vibration was changed. The depth of the measurement of the deformation of the tissue was changed. So an entirely new spleen probe was developed, and by using this probe, it was a much better differentiation obtained. So this will be the new spleen FibroScan that will be soon available on the market, dedicated for spleen stiffness measurement. And using this new probe, we were able to obtain better performance in predicting the presence of every grade varices as compared with the normal FibroScan, and we could differentiate very good between patients with high-risk varices and from those with low-risk varices. And a very good correlation was obtained with HVPG measurement. And an independent report came confirming these findings, and spleen stiffness with the new probe was the only predictor in multivariate analysis of presence of high risk esophageal varices in cirrhosis. Of course, it was not only transient elastography used, it was also point shear wave elastography used for assessment of spleen stiffness. And the first report came from Japan that demonstrated very much increased spleen stiffness in patients with idiopathic portal hypertension as compared with cirrhotic patients and with patients with not such advanced liver disease. And also in cirrhosis, it was found a very good predictor of portal hypertension, but not very much for varices. The area under curve for predicting the presence of high-risk varices is quite good using point shear wave elastography, and the differentiation between high risk and no risk varices is quite good in a report from the group in Timisoara. Also from Japan, spleen stiffness was demonstrated to be the best predictor of high-risk varices as compared with spleen diameter, platelet count, or liver stiffness. And if you look very closely in this diagram, the black dots are patients with varices, and on the vertical axis we have the spleen stiffness. It was much better to classify patients with varices as compared with spleen diameter alone. The problem of predicting varices is very important, and the spleen stiffness was demonstrated in this report from Germany that is much better correlated with the presence of varices as compared with liver stiffness in various portal pressure intervals. So it will be much confident to use spleen stiffness in order to predict the presence of varices. And again, it was the sole predictor of varices in this report. 2D shear wave is also used for predicting spleen stiffness and the hepatic venous portal gradient. It's well correlated, and it's of course higher in patients with clinically significant portal hypertension in those without, and can be very well used to classify patients, mainly if you use two different cutoffs, one to rule out clinical significant portal hypertension and other to rule in. The performance is it's quite good also for any varices, and for high varices, not different from other methods. But what is important to be stressed out in this report is the applicability of spleen stiffness. If you are looking in, it was applicable in only 2/3 of this Barcelona cohort, as compared with liver stiffness, which was possible in almost entire cohort. So we have 3 elastographic techniques. Which one to choose? This report shows that it's either one is good because the performances are similar between transient elastography and shear wave elastography. So which one at hand is very good. Only use it if it's needed. And a meta-analysis came to confirm that it has a very good sensitivity and specificity for predicting both presence of varices or only high-risk varices with an area under the curve of 0.8, which is acceptable for a non-invasive diagnosis. Of course, you can use it together with liver stiffness in order to increase accuracy. In this report, it was used together, so only a small proportion of patients, of about 10%, was not correctly classified by using elastographic techniques. It's used also for prognosis. This report from Bologna demonstrates that higher spleen stiffness is correlated with increased mortality in a 2 years follow-up interval, and the best cutoff value is 54 kilopascals for predicting a 2 years outcome in patients with cirrhosis. It also predicts the decompensation after hepatectomy, together with a combined score of platelets and liver stiffness, and also the late recurrence, which is more than 2 years recurrence after hepatectomy. It's the only predictor of late recurrence in this category of patients. The prognosis, it's used not only by transient elastography, but also with point shear wave elastography. It's one of the best predictors, together with the MELD score and liver stiffness, for a various of conditions in advanced liver diseases, and also can predict the patency of a TIPS. A higher spleen stiffness is correlated with malfunction of the prothesis. So spleen stiffness is mainly used for portal hypertension. It may be a valuable alternative in adequate technical conditions, but somehow still needs validation. Its clinical utility is mainly to predict clinically significant portal hypertension and large varices, but can also predict clinical events, including survival and the TIPS patency. Which method? For the moment, transient elastography is the method with strongest evidences, but shear wave techniques seem to have similar performance. In terms of technical aspects, it's important to see the spleen in order to measure its stiffness, because spleen is hidden behind the ribs, so it's difficult to approach if it's not enlarged. So this is the reason why at least level 1 EFSIM competency is needed for evaluation. For shear wave techniques, either point or bidimensional, it's easy because you see what you measure. But for FibroScan, for transient elastography, it's a little bit more difficult. That's why the new probe, the spleen probe, comes with an 3.5 megahertz ultrasound probe in order to see spleen on the FibroScan. The same principle are used as for liver stiffness. So the patient should be fasting for at least 6 hours, and the measurement should be performed after at least 10 minutes of rest. It should be placed in dorsal decubitus with the left arm in maximal adduction, and the probe should be placed between left intercostal spaces, perpendicularly on the spleen capsule. It can be measured at any site, but the inferior pole appears to be more easy to assess. And for non-transient elastography techniques, the patient should be in apnea. When you use FibroScan, perform 10 measurements and calculate the median with an IQR less than 30%. For point shear wave elastography, reports were for 10 to 20 separate measurements, and also the mean or median is calculated, standard deviation or IQR for quality. While for shear wave elastography, it's important to have quality of the measurement for each individual measurement with a standard deviation less than 30%, and then the median of each individual measurement, which should be at least 3, is calculated. So spleen stiffness, it's not very difficult to use, but it's important to pay attention to quality criteria, and the inter-observer agreement is also important, and a certain learning curve it's needed to be proficient in measurement. These were a teasing for spleen stiffness. I hope you will use this method more often in the non-invasive assessment of your patient with advanced liver diseases. Thank you very much.
Okay, thank you very much, Horia. For the moment, there are no questions, but if any question will arise during the presentations, then we'll tell you so you can answer. So thank you very much once again for the presentation.